questions? Oh, okay, sure. There's just a little bit of a different, you know, that everybody honestly should have the advance directive. You know, in fact, they say, you know, younger people are probably more in need of an advance directive than an older person, because often with the older people, the discussions have been had and so forth, but younger people often need to have this in place. Yeah. Okay. Can you talk about DNR? DNR means do not resuscitate. So that means if your heart stops beating and you stop breathing, that you do not want the compressions and the ventilation to try to restore your life. We often, you know, as a hospice, actually, we cannot require that a patient have a do not resuscitate in order to come on hospice. But we often have to have the conversation about what it is and what your goals are for that treatment. You know, we live in a, you know, we watch ER and Grey's Anatomy and these shows on TV, and very often people are resuscitated and they're up eating eggs for breakfast the next morning, which really is not often the case for someone who has chronic illness. The likelihood of them recovering after CPR is very, very little. And CPR and resuscitation does not cure the terminal illness that preceded that event. So this is one of the things that physicians will initially talk to patients about. This is part of the Advanced Healthcare Directive, is to make that decision as to the do not resuscitate. Some facilities are now calling that allow natural death rather than do not resuscitate. It's a little bit different connotation. Yeah. Okay. So can I just clarify the first question that you want to know if, you know, when you're completing the advanced directive, kind of understanding what the life-sustaining, right. And you know what, that's probably one of the most difficult things about completing this is, you know, one of my favorite shows was Seinfeld. Have any of you ever seen Seinfeld? Okay. You remember when Kramer, he went to go do his advanced directives, and he's with the lawyer, Jackie Childs, who was a Johnny Cochran lookalike. So they're going through all these scenarios, and it was like, okay, so if you have this, what do you want? And it was just really kind of, you know, it kind of put a humorous side to the levity of the decisions, but we can't possibly predict everything that will happen. And so, you know, there are provisions that you could put in there and say something like, you know, if it seems as though I may recover, you can try a tube feeding for a limited period of time to verify that I can't. These are things that you would want to talk to your doctor about. And as specific incidences occur, or as your health changes, and your physician may be able to better anticipate what some of the problems are, you can then narrow down the scope of the things that you want. So, you know, initially an advanced directive is rather broad, and you can't possibly kind of come up with all the scenarios that may occur. But by having that conversation with the person that's going to make those decisions for you, hopefully they understand your values and your wishes and would be able to kind of extrapolate and make the best decision for you at the time. And then your second question. So what she wants to know is if your doctor is not willing to discuss the options with you, what should you do? Actually, one of the really good places to go is to your primary care physician, if he is aware that what's going on. Because oftentimes that primary care physician can get the information from all of the physicians that are involved and kind of help you make a decision. And hopefully your primary physician knows you best of all of them and is able to take that time. Other options are to seek a palliative care referral if the facility you're working with has that service available for you. Or ask to speak to social work. If you're with a hospital or an organization, oftentimes the social worker within the organization can really help you out. Yes, ma'am. I know I did. Mhm. 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 Well, you know, she was saying, asking regarding the statement that nearly 50% of patients are in pain, and who regulates that. And very often, you know, it's not regulated specifically that, you know, a certain criteria for pain or whatever. But very often it is the family that recognizes it and advocates for their patients to make sure that they are getting appropriate pain control. You know, for a patient in a skilled nursing facility, for the patient population that's greater than 80, you know, there are a lot of painful conditions that exist with that. You know, arthritis, diabetes, you know, just being bedridden can be painful. And so, you know, I very much rely on my families for my patients who aren't able to speak for themselves to recognize facial expressions and other things that indicate that the patient's in pain. I believe that one was, I'm going to have to go all the way back. I believe that was, Oop, went too far. There we go. I believe this was the Robert Wood, it was either the Robert Wood Johnson's or the Hastings Foundation that recognized or included that in their study. Sure. Mm-hmm. Right. There is no specific order. So there is no order in who gets to make the decision. Yes. Oftentimes it's availability. It's the person that steps forward and makes the decisions. Yeah. That's, you know, yes, ma'am. No. The attending physician can remain involved with the patient. Oh, I'm sorry. She asked if you have to let go of your attending physician when you choose hospice care, and the answer is no, that the attending physician remains involved with the care while you're on hospice. You can still go see your attending physician. They're still very much involved in the care.